rapid iterative charge adjudication for creation of a large gold standard cohort from the EHR data. And purpose is for clinical trial emulation. Because for clinical trial emulation, you need like as much 100% accuracy if you can get it. I'm presenting this paper and presentation at EMEA, and it's a group effort. So there are basically 3 groups that I've put in different colors. So myself, Kay, who works at BITS, professor, Yuli and Raj are BITS folks, so they are informatics people. The people whose names are in purple, they are adjudicators. And the one in this color here, brown, red, or orange, whatever it is they are the cardiologists. They are the experts for the study, clinical experts. And Dr. Aslan is the head of our department. So first I want to introduce that this, what is the nature of this talk? And I've attended a lot of talks here, and this is a little bit different. Because I've heard a lot of, LLM talks and, all the modern technology. Our aim was to create a curated gold standard cohort that captures clinical reasoning. So it's a hybrid model where you have computer algorithm and you have human curators or adjudicators who kind of go from whatever, let's say you have 80% accuracy or whatever, 85. It goes for, they look at all the cases and go, from there to as good a gold standard cohort as possible. And the technology is LITE. That is basically rule-based NLP with regular, using regular expressions. It's in like 1970s, 1980s technology. In those days, there was this term called knowledge engineering, where the idea was that the data science people and the clinicians are, all that are in communication, and both of them are learning about each discipline. And so, it's they try to be at least enough of an expert in each other's domain that they can understand each other and kind of, so in the algorithm, you try to put in the clinical reasoning. And so I submitted it to EMEA, and I wasn't really confident that it would get accepted, because I think the theme of the EMEA conference is the modern technology, LLMs and all the modern AI. But I was, pleasantly surprised that it was accepted. And one of the reasons I think is that this approach is perhaps relevant to solving the last mile problem of clinical AI. So what is the last mile problem? Now, with all the modern AI, with all the LLMs or best NLP techniques, you can get to 85%, 90% accuracy as of the level of the specialist. But there's always some gap, and there are some applications where that's okay. Like if you're screening a large population, you get 90% or 85% even, it's fine. But in a clinical trial, you want like as close to 100 as possible. And so there are 2 components of this last mile problem. One is the hiatus of machine experience, which is that the machine may not be trained in enough in the kind of data that you are examining. And that may be one reason, and another might be just the limitation of all these technologies that you cannot get to full accuracy. So accuracy has to be at the level of the specialists. And the second is the hiatus of human trust. So the machine tells you that this is the answer, but you want to know why is that the answer. And I think in the last talk, Kevin had given some examples of trying to find out what the machine is thinking, or at least what's going on in the neural net. But without a clear answer to anybody who's, let's say, treating a patient, it's going to be hard for human beings to trust that, because you don't know what it's based on. It might be just an artifact of the kind of training set that the machine got. So you have to have some clear-cut reasoning that the machine presents in order for this trust to be there. So for that, you need very accurate labeled cohorts, and also I think there has to be some change in the way these large language models and neural nets work. So the challenge of a clinical trial emulation is to create a gold standard, and we try to create over 10,000 cases at the VA from the EHR data called Vinci or CDW, and the idea was to do a virtual emulation of a randomized clinical trial. Now, a randomized clinical trial is the gold standard, or the absolute pinnacle of clinical medicine research. Whereas if you do retrospective studies in EHR, that's not considered to be as reliable, or it's not that accurate, not that prestigious, because you cannot be sure of causal effects, causal inference. It's like a correlation, but not it's not causal inference. And there's been a lot of work done in causal inference in observational studies, and one of the pioneers in that field stated that the way to get it as close to an actual trial is to actually design a real trial, and that would answer whatever question you want to be answered, and then emulate the protocol as closely as possible in your EHR. So we emulated this randomized clinical trial called CSP 592, which compared two groups of patients. The groups were 70-year-old patients who have heart failure. So their heart is weak. And so one group received just drugs, that's the control, just medical therapy. And the other group received a device which is implanted inside. And what that device does is that if the heart fails, like it stops pumping, then it can shock the heart and cause defibrillation, so the heart rhythm is restored. And so it prevents sudden cardiac death. So of course, there's they have to implant the device, so there is some risk to it. So you want to see whether people who are just on medications compared to people who get this device, who survives longer. So this is the trial that we did. And so the statistical techniques for doing this causal inference in retrospective data are well established, and they're quite rigorous. But the problem is our EHRs are very error-ridden. In the we have, like, anybody who's worked in EHR, you work in the structured data. There are all kinds of data might be missing. data might be wrongly coded, all kinds of things. Even the values may not be reliable sometimes because they're outside the range of a normal human being because somebody typed it wrong. So all these kinds of problems are there. So and especially the very complex conditions, which might be your inclusion exclusion criteria for the trial. It's very difficult because they may not be coded properly, or they may not be, they might be mentioned in the doctor's notes, but they never get into the structured data. So, the GIGO principle applies, which is garbage in, garbage out. So we need to have as perfect data as possible. In a clinical trial, the data is perfect because every clinical trial, they have MDs and research coordinators who look at every patient who's enrolled in the trial, and they look at the whole chart of the patient, and they there's no chance of errors of wrongly assigning controls to a patient, or wrongly including patients in the trial who shouldn't be there. So that's why the randomized clinical trials are respected as the final word. So in order to and as I said, the diagnosis that you might be looking for are might be undercoded or miscoded, or some structured data is just not available. So so in this trial, we had like multiple inclusion exclusion criteria. We had most of them did not have the structured data, so we had to go into the nodes. So our vision was that we want to, if we can verify that the structured data is accurate, then of course we use it. But if it's not, then either we go to, if there's some database outside the normal ones that we're looking at, we can go there. And the idea is that every patient is adjudicated manually, just like in a real clinical trial. So now, when you do a retrospective study, there are some differences from a real study. In a real study, let's say the patient is referred to the doctor or who's conducting the trial, and then the patient is randomized to one of the arms. So the patient has to be healthy enough to do that, to be referred, and the doctor has to examine him and check that whatever treatment they're doing in the trial, the patient can withstand that treatment. But in the EHR, this may not be so, because we have to, the patient is not actually going into the trial by themselves. So, so sometimes what happens is that a patient goes into the, into some kind of crisis, and there are, it's an emergency situation. The patient is in danger of dying, so they implant this this device, and obviously that is a different situation from getting the device, by choice. So that kind of patient would never be included in the trial. So that is, this is called secondary prevention. That means this implantation was done to prevent the patient from dying. And so, so when they wrote the protocol for this trial, they hadn't even thought of secondary prevention, that they might be, because they were thinking of a real trial. But when we started looking in the, in the EHR, we found that some patients actually, they had some problem, and they went to the hospital, and they were in danger of sudden death, so they got this. Obviously, those patients have to be excluded. And this was actually discovered by this process that I'll describe. So we had to change the protocol to include that exclusion of secondary prevention. And of course, in a real clinical trial, every statement that you make has to have a supporting document, which is known as a source document. So we wanted to make the same thing here. So for every piece of data that we use from the real, in the retrospective trial or the emulated trial, we need to have some note, doctor's note, or some report that supported that. So, I mean, we won't go into the actual details, but there are two things that these are the 9 or 10 criteria. With the first two are inclusion criteria, and then the others are exclusion criteria. So if the patient has to be in the trial, they have to have both the first two, and then if they have any of these other ones, then they're excluded. Now, very few of these had structured data that we could use. In fact, all the ones that have arrows going we have to go to clinical notes. The first one is the most important most important criterion, which is it's known as LVEF. Also, the full form is left ventricular ejection fraction. It's also called EF. And the way to think of it is that your heart is pumping blood with every stroke. So the blood goes in when the heart is relaxed, and then it pumps. And the ejection fraction is the proportion, the percentage of the blood which is pumped out. So out of the 100% of blood that goes in a normal person, something like 60-70% goes out with every stroke. But in these patients, that the heart is failing, so the EF value is 35 or less. So in order to qualify for this treatment, they have to have LVEF value of 35 or less. And we also have to know what date it was measured, because that is the start time zero of the trial. So for both these things, in our database, they have actually a table that they created using NLP to give the values, but they don't have the dates, because the values might be anywhere in the note, and they're not linked with what day the measurement was done. So even though those values are there, and of course, even with the values, there is some problem. And of course, dates are not there. So this we had to get from the notes with NLP and a manual correction. And this other thing, which we'll come to later, but it's basically, there are some conditions where you need a different kind of implantation, where instead of the ICD device that we're looking at in this trial, we need another device called a biventricular device. And there are several conditions that make the patient need that other kind of device. And these are known as LBBB, IBC. We don't have to get into details of that. But again, for all of these, there's no structured data. So we have to go into the notes, find out whether the patient has any of these conditions, or if in this is the width, so that's in milliseconds. Pacing is a percentage. So all these values we have to get. So as you can see that you have to do NLP for something like 6 to 9 different things, and they're all pretty complex. So most of these NLP projects are pretty time consuming. They need a lot of people, personnel, and a lot of computer resources. And also in our CDW, we do not have the many of the app, because it's like it's protected space. They don't have many of the applications that, especially they don't have the modern applications to do machine learning, things like that. So we had to use very simple. Nowadays, actually, at the VA, they're creating a cloud. They're already created, and you can get some access to these, but I think only for some specified projects. Anyway, so this is where we were, and so what we decided is that we'll use this very simple NLP-lite, which is rule-based, focused phrase searches. So normally, when you do, you might do all possible concepts that are in a node, but you don't have to do all that, because we're looking for very focused things. So you can just do all the possible ways that a particular condition can be expressed, and do searches only for that. And of course, other standard NLP techniques like proximity searches, negation, sectionalization. Again, you don't need them in every case, so you use them when necessary. It's all very focused for just for the purpose of getting the data that you want. Then you extract snippets of 100 to 120 characters from these nodes, and you rank them according to how relevant they are. And the ranking is based on context words, which you can weight, whatever is important to your project. And you take the top 5 to 7 snippets, or sometimes even less, in a easily navigable display, and then you have to have somebody look at it. And the time of the specialists is very extremely valuable. So you cannot have the specialist looking at 10,000 cases, because each case might take 20 minutes, whatever, so nobody has, it's very difficult. So that's why we had to come up with some way that a combination of semi-specialists and naive people who didn't know anything about this subject can start doing it. And in the process of doing it, the people who are naive get trained by kind of group dynamics. And so you do that in an iterative process, and every process improves the algorithm, because you get feedback what is wrong, and at the same time the people get trained in a better way. And sometimes while doing this, as I mentioned, new knowledge might be discovered. And as I mentioned, that there was one case where we actually had to modify the protocol, because we saw that there are things that are happening in the nodes that hadn't been thought of in the protocol. And then we keep improving the algorithm, so that and you don't have to get to like the best possible one that you want, because anyway you're going to do a manual curation. So if you can get to anything anywhere up about 80 to 85%, that's fine. Whatever you can do without, because as you can get to a certain level with some ease, and then after that, even to increase 1%, it becomes very, very difficult. So you do a few iterations till you get into a level where the number of cases that actually have to be manually decided is low. So this is the kind of display that we gave to the adjudicators. And we used Excel because everybody's used to Excel. So there's no learning curve. So you can see that each of these rows it has a snippet, and each of them is from one particular clinical note. Each of these represents one note. And then you also see those colored bands. So each of those represents one patient. So in the first case, there's only one snippet. In the second case, there are two of the same patient, and so on. So, and all the columns right up to here, the report button, are generated by the computer. And the adjudicators have to answer some very simple questions here. So now what the purpose of this is to find out the EF values. And you can see that each of the snippet has EF values. These were actually very easy cases where everything is very clear cut. So, so you can see that here EF is 15 to 20%, and that is what the computer has found, 15 to 20. So all that the person has to do, it doesn't require rocket science. You have to look here, you have to make sure that it's EF or ejection fraction or some other synonym of it. It's not, there's nothing that says that there's anything, it's not negated or anything like that. And it matches what the computer extracted. So in this particular instance, for example, all of these were correct. And also there are dates there, and the date in this case is the document date, and it has to match the procedure date. So so all that the adjudicators have to do is to check the numbers, check the date. Say if anything is not right, you can give a comment, and it's very easy. Anybody can do it. And you can see here, for example, the adjudicator put question marks because it says you're unable to determine LVEF. So in that case, what you can do is click on this button, and the whole report will pop up, and you can get more context and make a decision based on that. So this is what happens. That this is a part of the report. You can see actually here that there's a misspelling of thrombus in that last sentence there. And also there's some other things here that's worth looking. See, it says 35 to 40, and that's over there is it's 30 to 40, and that's correct. But you see other EF values here. There's 34, 35. And the reason for that is that sometimes when they measure, or many cases when they measure EF, they measure it by different ways. And only one of them is the one that the clinicians use. These are all machine estimates which rely on some assumptions, which especially in patients may be wrong. So that's another thing that they have to look at, that the correct EF value was captured by the algorithm. So how did the whole process work? So we had some cardiologists who are our final experts, super experts. They gave us their, what we should search for and what the logic should be. And we created a search algorithm and generated the data. And then then all the adjudicators got together and as a group did 50 to 100 cases. And who are the adjudicators? Like I'm one. I went to medical school, so I understand I have some general medical knowledge, but I didn't know about this particular subject in detail. There were 2 trial coordinators, that is, they had taken part in the real trial. So they have some content experience, so they are pretty well versed with this material. There was a trial nurse, so she also had some content experience. These 3 were research assistants. He was a statistician, so they didn't know anything. So even these kind of people, for the kind of task that we gave them, I mean, it's pretty simple, because these were the very easiest cases that I'm showing you. But there are far more complicated, which I can show you examples later on. But in the meantime, these people, just by doing it, they come across cases and they're getting trained. And then so we've already done 50 to 100 cases together. Then each one is given another 200 to 400 cases to do individually. And any cases that there is any ambiguity, again, the group meets and we again discuss among ourselves, and there is enough expertise in the group that we can come to a conclusion in most of the cases. If there is any issues that require clarifications or any unresolved cases, and generally it was less than 0.5%, we go back to the cardiologist. They will look at what they've given us, and if it has to be changed, then they'll change it, and so on. So this, a few times you do it, the algorithm becomes better and better, and you can do the same procedure for all the values that you want, all the conditions that you're looking for. So we did about 11,000 cases. 9,700 were total patients, so some of them had more than one. And the number of implanted, so these were the cases, and the 9,700 minus, so about 7,200 were the controls. And to show you how much adjudication had to be done, so I already showed you the first one, that is LVEF value and date. There was only 3% structured data. So initially, when we did the first NLP iteration, we only got 50%, and we had to, but finally, within a few iterations, we had improved it to 85%. And mainly it was because the date was absent, and we had to figure out what the date was. Then these other things also initially, either there was no structured data or very little structured data. So all of these, the same thing happened, and finally we got to pretty respectable accuracy. And so the question is, how much time did we save doing this? So we had the adjudicators look, do the chart review, either the regular way that they had been doing for a long time, where they actually look at the patient's chart, and you can see that the time per lookup was 4 to 10 minutes. Sometimes they might take even 20 minutes, even more than that, if the patients had very complicated charts. Whereas the median lookup time for the rapid adjudication display was less than a minute. You can see that, in that example I gave, you can actually do it in a few seconds, that you can confirm that the value is correct or wrong. And so for 60 lookups, you're saving something like 5 minutes per lookup. So that's about 300 hours, which would have taken 300 minutes. so 5 hours you're saving for 60 lookups. So also the feedback from the adjudicators was that it's easier to learn, it's convenient, it's faster. Very few cases have to be referred to the super experts. Those who are naive initially gained confidence and proficiency by group adjudication. And the drawback was that for some data, which like in the charts, you can have scanned documents or faxed PDFs from outside hospitals, things like that. Those were not available as text in the EHR, in the digital EHR. So sometimes when we could not adjudicate the case based on what was there in the digital ER, they had to look at those things, and that was in about 2 to 3% of cases. So what are the lessons we learned? Through each iteration, as the computer algorithm improves, the adjudicators have to actually pay attention to fewer cases, since if everything matches, it's very easy for them to do it. So the difficult cases become fewer, and we also found a lot of problems in the EHR, and this actually makes me think that whenever you get data out of any medical record, you should, something like this process has to be done, because not all sources of the same data element are equal. So you can have, there are so many different tests to measure this quantity of LVF or EF, and also those values are mentioned in many notes, and some are more, some are reports which were actual the reports of the measurement, where others are just doctors who cut and paste from some old reports maybe. So you have to be very careful where the value is coming from. Also, some of the tests that they used to measure are more accurate than others. So again, you have to look to see what test it was that was done, and you're taking that. In this case, these MAGAs or echoes are better than these other kind of imaging. So that is one thing. And then, as I showed you, that in the same test, you can have multiple measurements, and you have to look for specific ones out of that. And those measurements may not, they're not necessarily the same. Sometimes they can be so different that, it might change a patient who was qualifying to a patient who's not qualifying. So again, the source of data is very important. Then, of course, anybody who has looked at doctors' notes know that it's not, clinical language is not natural language. It's filled with all kinds of, shorthand, abbreviations, typos, templated, bullet language, telegraphic language, and jargon, which is, every specialty has their own way of saying things, and even different institutions, they use different jargon. So, the normal parsing of sentences, just may not work. And we found many times that things like this used to happen. For example, we saw text 2/2, and our algorithm, interpreted that as a partial date, that is 2nd of February. But actually, the 2/2 is it's actually shorthand for secondary 2. That's, so they say this patient has certain condition, 2/2 such some other condition, secondary to some other condition. There are all kinds of things like this. So when you actually look at the snippets, you look at the notes, then you realize how, if you have any algorithm that's going through that, it would be impossible for it to get the right answer. Then, of course, as I mentioned, you can get some implicit conditions that the protocol, people who wrote the protocol may not have thought of, which is present only in the EHR, but not in the real trial. So again, you have to be careful about that. And what we found is that the clinical decision tree that our super specialists gave us, that also gets improved, because we give them the feedback and they realize that, you know, they're not perfect. So they haven't thought of everything. And they realize that they have to, you know, that sometimes something might be expressed in a different way, or, you know, they forgot to add some clarifications, things like that. So, you know, this iterative feedback process is very, very valuable. So this again is one example of that. So our initial, you know, initially our experts give us that, you know, for this criterion, you have to look for these three things. You know, that you have to look for this LBBB. You have to look for, which is, you know, it has a full form, but we don't need to know that. IVCD, and this QRS duration has to be greater than this 130, or there has to be ventricular pacing, which is greater than 40%. So these are the three things they gave us. But when we actually looked at the notes, there were so many different ways that all these things were expressed that they had to add like 8 conditions, you know, which are over there. And again, you know, for a person who's adjudicating, you have to, so in our first iteration, you know, obviously we were missing some cases, but then when we found that these other clarifications are there, then we started getting more and more yield and accuracy. This is that criteria, snippets of that. What we added here is the actual clinical reasoning, because we had the whole logic that, you know, those 3 main characters have to be there, and it has to meet all those conditions. And so, you know, from the algorithm itself, we gave the reason why the algorithm thinks that this patient should be excluded. And in most cases it is correct, but in this case, for example, it's, you know, it should be a yes instead of a no, in this case also. So so this is you know, the way in which you can get greater and greater accuracy. So you know, finally you can get an accuracy of 90%, which means that, you know, in 10,000 cases, you're only looking at you know, about 1,000 instead. So you're cutting the amount that you actually have to go into detail by a lot. So what is the relevance of this approach? You know, it could be used in so many different places where you want absolutely, you know, as close to 100% as possible, where structured data is not available, like, you know, population diseases screening, clinical trial screening, in actual clinical trial, actually, you know, you can use it, finding drug interactions, adverse drug events, things that, you know, you will not find in any structured, you know, as structured fields in an EHR. Then the other thing is, you know, for machine learning, you need models that are labeled. So it could be used as a training input for unsupervised machine learning models, where the large amounts of label data is required. And as I showed you that, you know, for any specific problem, you can train people who have had no previous experience of that field. And finally, the last mile problem. And so generally, when LLMs are trained to, kind of recognize a condition or any kind of application, you give them the final output, and they're trained on the final output with how many millions of parameters. But in order to capture the clinical reasoning, another way to do it is, instead of doing the outcome supervision, that you're comparing the outcomes, you can also try to do process supervision. So you take one particular condition, and in the clinical decision tree, you can have so many branches. So you go to the root of it, you make sure that you train only for that and get close to 100% accuracy, and then go to the next one. I mean, I'm not an expert in LLMs or the machine learning, but this is something that people have looked at, and they feel that you can get more accuracy when you do this process supervision. So the kind of clinical reasoning is embedded in the networks much better. So it is possible to get a large and highly accurate cohort with just simple NLP and iterative clinical validation. And this display you can do rapid and simple adjudication. The continuous communication and feedback is very important, and especially if you have somebody who knows both fields. I mean, the cross training. I think that every data scientist who's working on any application should try and study as deeply that application, the actual clinical things that they're looking for, because that's the only way you can catch errors that because the clinicians may not be as intimate with the data that you are, and you will be able to catch that. Otherwise, it will just go unnoticed. And finally, this idea of doing process supervision to capture clinical reasoning, I think that can make the output of the NLP or LLM systems more trustworthy for the human beings, because then you can actually relate to why they're giving that particular answer. So that's it. These are some of my co-workers. Actually, Professor K is, he had started this kind of approach before, and we kind of ran with it, and we fortunately had some very good people who could put that into practice. So that's it. Thank you. And any questions?
Thank you for your speech. So I have some questions. So the first is, like you said, there are many inaccurate information in the EHR data.
Right.
So is this common, or the inaccurate data would be a small part of the EHR data?
Well, not necessarily. It could be a large part. And especially, let's say it is like 80%, 90% accurate. But if you are looking for 7 different things, and if each of them is 80%, then finally your accuracy for the whole thing goes down to very little, right? So that is a problem. It compounds, if you're looking for more than one. That's why most of these in the literature, you find they are studying one thing, and you get 80, 85%, 90% accuracy in that one thing. But then if a patient needs to have 3 or 4 different things, each of them, you can see how it can decrease.
You make a good point. So the next question is, if that's the case, will the structured data still be an important source for this kind of like cohort searching?
Sometimes it can be. Like, for example, we find that drug data is quite accurate because they have the prescription, the drug is there, dose is there, everything is correct. But like even primary diseases, the coding is there, the ICD-9, ICD-10 codes. Those are accurate for main conditions, but for subsidiary conditions, I mean minor conditions that people they don't code it that well. So for those, and the other thing is that in those diagnostic codes, the definitions might change from year to year. So you've got to be careful about that also. We also found that in a couple of codes, for example, there was one code for depression that was ambiguous. So you had two different diseases that had the same code. And then for 5 years, that was the case. And then, I don't know, somebody might have realized, so they invented a new code in 2021. But before that, we could not separate just by the structured data. So you have to go in the node and see what the provider said, and then only then you could get. But even that's hard though. So yeah, you have to be careful. I mean, the structured data also, sometimes there are typos if it's manually entered. So that's another thing. So again, you have to always look for, do the values make sense? And for that, you have to know a little bit about the subject.
Thank you.
So thanks for your talk. So I have two questions.
Yeah.
The first question is, we use experts to provide the reasoning. Right?
Yes.
So if two models, they all get the final label, the answer correct, but actually one got wrong reasonings and the other one get right reasonings. So the model got wrong reasonings just happen to get the right label. So my question is there a way to evaluate reasonings?
Well, many, there are clinical guidelines, which is supposed to be, the best guidelines, which is like in our case, for example, we had 4 experts, and they, they meet every 2 weeks, and they, of course there are, sometimes there are different interpretations, but they come to some common thing that they agree on.
Is there some quantity, like disagreements number to calculate to see how well 2 experts or 4 experts agree with each other? Do we actually see after trial by trial they more likely agree with each other afterwards?
Yeah, I'm sure you can see. I mean, you can calculate, some scores of what is their concordance, but there are probably statistical techniques for doing that. But in general, I think for most cases, the disagreements are minor. It's only for very rare things that two experts will have really different views, major different views. Mostly it's and if they're talking to each other, they come to some conclusion. Also, there are guidelines which are published. So and those are again super experts who are in conferences. They decide what the guidelines are supposed to be, and those guidelines are to be followed. Those are the ones that are followed by everybody, or supposed to be followed by everybody. So
did you release this data set?
Not well. This is our data set. We are going to release it after. Yeah,
I see. And are you going to do the process supervision to train some model?
Well, I hope somebody over here can do it, because it's very hard to do at the VA.
And so OpenAI actually had a paper called Let's Verify Step by Step.
Okay.
It's doing the process
Uh-huh.
vision. process supervision.
Right.
The last question is what is the average length of reasoning? Does it follow a step-by-step format like solving a math problem?
Yes,
it's like step 1, step 2. Do we have similar format?
Yeah, most of the clinical guidelines are like that. You look for one thing, or there might be a score. You look at 10 things, you get a score, for each one, like 1, 2, or 3, and then you add all that, and if it is more than certain amount, then yes, you have that. Or some cases they say if you have there are some major criteria, some minor criteria. So you have 2 major and 1 minor, or 1 major and 3 minor, then you have that is you have to make this diagnosis. So it's a lot of it has very clear-cut logical reasoning.
Did you use some like GPT just to do a zero-shot performance?
I think it could work here for zero-shot, or maybe some training with the data sets, but we did not have access to that. Yeah, I think it could work. So but the only thing is that then you don't get the reasoning part. You cannot say why it gave you positive, or
why not? We can change prompt to like large enough to give us reasonings.
Yeah, maybe I don't have experience with that, but I think some papers I've read, they say that most clinicians, they like to get they have to agree with what reason is given before they will accept the output of the chat GPT.
So I think the latest GPT-1 has the tendency to it can generate explanations.
Mm-hmm.
Yeah, but its generation can be slow because it's kind of a step-by-step reasoning and self-correction.
Yeah, what is it? Which one is it?
GPT-01.
01.
Yeah, the latest version.
Oh, okay.
Still very models.
Mm-hmm.
Yeah, but it's quite expensive to call it
That model
Really
is
very
based a process.
Oh, it is. Okay. Yeah, it's very exciting, except that with medical data, it's I don't know, at Yale you have it, right?
Yeah, I guess we are working on that. We can in hospital, maybe we can use Microsoft manage the Azure cloud.
Mm-hmm.
This de-identify.
This is not.
Okay,
I mean, I just de-identified to show in the slide, but yeah, it's not de-identified.
We cannot blindly.
Yeah.
But it's impossible to generate a de-identified set that.
For AA, I don't think so.
Well, you can. The thing is that many things are date dependent. So date is, that's part of PHI. So if you don't give the correct date, then you have to, if there are like 5 different dates in the patient, then you have to give the same offset for each date. So you know.
Just like what Binming.
Yeah.
They shift the date, they mask the date by some de-identification.
Yeah, right.
Yeah, it's possible. It's just hard, and there are always some things that you don't know. But I think I think that nowadays most institutions are creating their own cloud, where if you have research access to that, then it's all identified data, but it's secure in the cloud.
Yeah.
At the VA also they have done that now. This what was his name? Just at the last meeting on Monday, he was saying, right? I don't know, but it's that Oak Ridge and Summit project that VA has a cloud. So I think we should try and get access to that.
Oak Ridge has a cloud, and they also have a technology suite to allow remote encrypted access to computing on private data like that without ever having access to the private data, so it stayed anonymized. It's really cool.
Well, which
Oak Ridge.
Oak Ridge, yeah.
They MIT also has a part in it. It's
Yeah, I think we should try to get access to that, because with this you can only do simple things, but with once you have that in the cloud, you can do this latest GPT and all.
Yeah, maybe we can also run those like Llama 3.1
Yeah.
model within that cluster.
Because de-identified data is too difficult. You do it on real.
Right, definitely. Okay.
I'm not sure if you can speak to this level of detail for the algorithms that you used, but do you know if you more specifically used semantic analysis techniques over a large language models? Because it looked like for the data you used a tokenization,
Right.
and then a nearest neighbor sort of thing going on.
Yeah, and a proximity.
Yeah, that sort of looked like what was going on. But I don't have your code. So just wondering if that was what you're actually using to do your semantic analysis or your natural language processing, because it wasn't directly brought up.
Yeah, so normally when you do natural language processing, you do like tokenization, and I mean you're interested in all the concepts there, right? So you might look up or use UMLS or something to because but what we were looking for was very focused. So we had only a limited number of words to look for. For example, in that LBEF, there might be a lot of things around that which we were not really interested in, because we had to get the accurate values only for that. And even for the second example I showed, there were about 10 different things that we were looking for. And so the number of concepts that we are looking for is very small. So there was no need really to do semantic analysis. Also, we are not aiming for incremental accuracy, because as long as you can get anywhere above 80%, 80-85%, you're going to get that that snippet and that node in front of the adjudicator, and then you don't have, so after a certain level, we are not trying to get the maximum out of the algorithm. We are only getting enough to make it workable and easy. So yeah, what you're talking about, yes, you can do, but each little thing adds maybe 1%, 2%. So to get to the final, you have to have, I guess maybe in 10-20 years, the these algorithms and these LLMs will get as good as the specialists. But also the problem is that they have to be trained on that data set, because general training may not work, and every EHR, I think, will have its own idiosyncrasies. So you have to train on that particular set.
It was more based on regular expressions.
Yes.
Answering.
It was 1980s, 1970s.
Well, I didn't want to be too wordy with my question.
Yeah. Okay. I guess maybe already 30. So yeah, sorry for that.
Thank you.
Yeah, thank you all.
They started